Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation.
Welcome to Coffee Connections. I'm Claudia Vasquez, Director of Annual Giving and Operations for Sun Health Foundation, and I am thrilled to be your host today. This is, by the way, one of our best yet, and clearly it's a topic that everybody wants to hear about, very relevant. If you're new to Sun Health Foundation, we'd love to stay connected. You know, for nearly 60 years, we've partnered with generous donors and volunteers to support high-quality care and wellness programs across the West Valley. So now let's take a quick look at what we're working on now. We are the philanthropic partner for Banner Boswell and Banner Del E. Webb, and we're currently wrapping up some of our initiatives that we've been focused for the past 2 years. We completed the construction of for the expansion of the obstetrics unit at Banner Webb, and we're really excited about that. Of course, just a little bit of fundraising to go, and we are all set with that. The other project that we're also open our doors to is the expansion of the endoscopy and interventional radiology space suites over at Boswell. We are continuing to support health and wellness education like the Memory Care Navigator program. Of course, we work with the Banner Sun Health Research Institute. We raise support for scholarships. And if you want to know more, on your way out, some of you might have received this already in the mail. This is our community impact report, and it shows stories, numbers about the success we've had. Again, thanks to volunteers and the support of this wonderful philanthropic community. Thank you. So together, you know, these initiatives that I just mentioned help to ensure the outstanding care and the healthier futures for our community. And incidentally, if you're looking for an easy way to support our mission, you're welcome to shop at our resale shop. We have one here in Sun City West, and in fact, there's a coupon at your table so that you can feel so inclined to use it. Get a 25% off a little gem you might find at that store. Another program that we recently also launched is donating a vehicle. So if there's a vehicle you no longer use, you can donate it. It's easy, it's free, and it's tax deductible, and every donation makes a difference. So now we know why you're here. Let's turn our attention now to Dr. Gimbel, who I'm excited to introduce. He's a surgical oncologist specializing in melanoma and skin cancers with training from the University of Maryland, Montefiore Memorial Sloan Kettering, and Moffitt Cancer Center. Dr. Gimbel brings world-class care right to our doorstep. Please join me in welcoming Dr. Gimbel.
All right, good morning, everybody.
Good morning.
Thank you for allowing me to be here today to expound some sun health, sun safety knowledge to you. I hope this is an interactive process where I'm going to kind of go through some slides and talk about some things. You all have notepads in front of you. Please write down any questions you have. I think after the talk, we're going to have a pretty robust Q&A, and I'll try to get to all your questions as much as I can. In a setting like this, try not to make it too personal about you've had this cancer and what should we do, but more of just kind of some general things I think that will be a little bit more applicable to everybody. So we'll just try to make this a fun time, an educational time, and we'll go from there. So as Claudia said, my name is Mark Gimbel. I'm a surgical oncologist, which means I cut out cancer. But when it comes to oncology, we don't just cut it out, it's how do we treat it holistically multidisciplinary. It's not just surgery. It's what are other things that we can do to take care of patients. And so we really put a whole program together to take care of people, and that includes skin cancer and melanoma. I don't have anything to disclose in terms of conflicts of interest for this discussion. So our founder is Tom Lewis, and our founder, but one of our benefactors is Tom Lewis. He is a home builder in the Valley, has been here for years. He gave us a really nice gift to be able to build this Melanoma Center of Excellence, which has allowed us to now do these outreach talks, to do education, to expand the treatment to across the entire valley. We've now been able to start a lot of clinical trials. We have a database where we're following all of our patients to be able to monitor them and learn from them. And then survivorship. What happens when someone's done with cancer? Now what do we do, or what do our patients do? And we've been able to bring all this together into our Melanoma Center of Excellence. So I think when we talk about sun safety and sun health and skin health, we have to understand the skin. Okay? So the skin has two layers to it. It has the epidermis, which is what everybody can see, that's the outer layer, and then it has the dermis. All of the cells that we're going to talk about today, the skin cancers that we talk about, start in the epidermis. That's where I call them the stem cells for the skin. You have those basal cells, you have the squamous cells, you have the melanocytes, you have nerve cells that can turn to cancer, you have glands in the skin that can turn to cancer. But we're going to focus on the squamous cells, the basal cells, and the melanocytes. And as you can see here let's see if I have a pointer here. Is this a pointer also? Is this a pointer?
Yes, there's a laser on it.
Okay. Let me just see which, there we go. Thank you. Right there. Okay, so this is this is called the basal layer, or the separation between the epidermis and the dermis. And in the dermis is where all the blood vessels are, and in the epidermis is where all these cells are. And the basal cells are at the bottom, melanocytes are here, and then the squamous cells are here. And all of these can turn into cancer if you get enough radiation from the sun throughout your life. And so each one is a little bit different. The basal cells are the most common, but they're actually the least aggressive of the cancers. So they're more, I call them more cosmetic, because once you get them, they can grow big, but they don't really do anything. Squamous cells have a higher risk of spread, but still pretty low. And then the melanocytes, which turn into melanoma, have a much higher risk of spread. And that's why some of these skin cancers can be very aggressive because of their risk of spread. I'm sure all of you have heard of Jimmy Buffett. Not all of you, but most of you probably heard of Jimmy Buffett. He had a Merkel cell carcinoma, and that's actually a cell that's one of the nerve fibers that comes up into the epidermis as well. Bob Marley, he had a melanoma. So these things happen and can be much more aggressive when they spread, and they can potentially be lethal, but if we find them early and stop them early, they can be curative. So what is cancer? When we talk about cancer, cancer can happen anywhere in the body, but really what is it? Well, there's two mechanisms to cancer that can happen. It's either the cells grow uncontrollably, where you now have a small growth that can go big because these cells just continue to grow, or the cells stop dying. So the cells all cells are programmed to die. But if there's a mutation and you lose that programming where the cells can't die, they continue to grow as well. So there's tumor suppressor genes, which keep everything down where it causes the cells to die. And then there's growth factors, which allow the cells to grow. And neither of these are out of regulation. So we can start to see cancers, and they're mutations typically in the DNA or the genetic structure of the cells that can happen. And how do we get that DNA damage, especially in the skin? Well, that's radiation. And where does the radiation come from? That comes from the sun. That's ultraviolet radiation that can, over a lifetime, can start to just pound the skin and cause these mutations to occur. And then we can start to see skin cancer. And that's why typically for skin cancer, it's a cancer as you get older. We start to see it more because you've had more radiation exposure throughout your life. And now the cancer cells are starting to mutate more and more. And then we start to see this kind of accelerated growth throughout life. So overexposure to the sun is going to be the main reason for people to get skin cancer. When we talk about sun exposure, it's not just skin cancer that we're concerned about. We also talk about wrinkles. We talk about the skin gets thin. It can start to lose its elasticity. There can be a lot of problems with overexposure to ultraviolet radiation throughout your life, and we want to try to prevent that from happening moving forward. Now, a lot of you are looking at me and saying, well, I've already had it all. What can I do now? You know, I'm already at that point where I can't really change what I've done in the past. And that is true. What's done is done. You cannot change the effects of ultraviolet radiation. Whatever's happened to your skin already has already happened. If you've had skin cancer already, you're going to get more skin cancer. That being said, if you continue to go out in the sun, you continue to play golf, you continue to sit by the pool, you increase your risk more and more every time you do it. So even at this point, if you can lower that risk or stop that risk from progressing, you will do yourself and your body a significant favor. So when it comes to ultraviolet radiation, yes, it's from the sun, but it's not only just getting direct impact from the sun. Even on cloudy days, if it's a light cloudy day, you think, oh, great, the sun can't get through. Ultraviolet radiation can pass through the clouds, and you can still get a burn on those days. And then if you are going to be outside, if you're at the pool or at the water, or if people like to ski even, you actually have a higher risk of getting ultraviolet radiation because those rays can actually bounce off reflective surfaces. So you need to be cautious about that if you are going to be out and about in terms of where you are on the beach with the sand. You can have increased reflection that it will actually increase your exposure. And it is cumulative. As I said, the more you get, the worse it can be. And so repeated unprotected exposure can really impact you. So who needs sun protection? The answer is going to be everybody. Okay? There's nobody who doesn't need sun protection. I don't care if your skin is white. I don't care if your skin is black. You need sun protection because anybody can get skin cancer. Yes, white people are a lot more likely to get skin cancer than somebody with black colored skin, but anybody can. Hispanics, Native Americans, anybody can get skin cancer. So we need to protect your skin. And it's not just skin cancer, as I said before. The more exposure you get, the more wrinkles you get, the more sun changes you get, and you want to prevent that if you can from happening. And you can see the numbers here, where even the African American population, while that number is going to be a whole lot lower, it is not zero. And I tell all of my African American patients, you got to put your sunscreen on, and they look at me and say, why? And I show them numbers and say, because you can still get skin cancer. I see a lot of Native Americans who've just spent their whole life out in the sun, and they get a lot of skin cancer as well. Hispanics, so it's prevalent. So takeaway is, doesn't matter what your skin color is, you still need to protect. All right, so and it's not just the skin, it's also the eyes, because these cells, you have melanoma, you have melanocytes in your eyes, they can also turn into melanoma. Sun exposure, chronic ultraviolet radiation exposure to the eyes can cause cataracts, and it can impact your vision as well. So you want to make sure you're protecting the eyes as well. The best thing to do is to stay out of the sun. Shade is the key thing that you can do when you're going to be outside. Well, if I'm going to be outside, how do I get shade? When I go to any of my kids' sporting events, or if I'm going to a concert, I have an umbrella. Because you sit under an umbrella, it's going to block those. It's a direct shade. It works really well. Now, people look at you and let you go crazy, but that's okay. I'm all right with looking a little bit crazy because they're going to get skin cancer, and I'm not. If you can be in the shade, I do tree hopping. You know, I jump from tree to tree to make sure I'm getting the shade when I'm walking from the parking lot, or maybe I'm a little too crazy with that, but just trying to find that shade so I can stay in the shade, I think is really important. The sun is the strongest between 10 and 4. Okay, so if you like to be outside, I'm not here to tell you don't go outside. I'm not here to tell you don't go in the sun. We need the sun. The sun is healthy for you too. You do need some sun exposure, but you just got to limit it. And if you can limit it to times where those ultraviolet radiation beams aren't as high, that's going to be better for you. So if you're a swimmer, don't swim between 10 and 4. If you're a golfer, try to golf early in the morning or the afternoons, or do the activities in the sun that you can when it's not in the direct part of the middle part of the day. If you are going to be outside, cover up. Clothing is great. Okay, it's hard to say in the summer wear long sleeves and pants around here if you're going to be outside, but that's key. And there's clothing that's actually made to breathe that actually has what's called UPF, ultraviolet protection factor, within the clothing, so you can actually wear longer sleeves or wear clothes that will breathe yet will still protect your skin. And here people think this is a typo where it says dark colors. Actually, we do like dark colors because light colors, same as I told you that white and the water can reflect, the white clothes can actually reflect as well. So the darker colors actually absorb the sunlight and the rays to prevent that reflection. When I go out in the pool, I wear rash guard. What's a rash guard? People who surf, they wear these things to prevent the surfboard from kind of cutting up their body, but you also have swim shirts as well, long sleeves. I'm out in the pool all the time, and I'm wearing long sleeves if I'm at the beach. I'll wear a hat until I get in the water, and then making sure I have my sunscreen on, I'll get in the water, but you want to make sure you're protecting the trunk as well, because that's how big is your trunk. It's one of the biggest areas on your body, and if you can protect that, it's only a good thing. Wide brim hats. Now I see a lot of people who wear hats. I have a baseball cap on and I'm protecting myself. Well, you're protecting this part of yourself, right, when you're wearing a baseball cap. But when you're outside, you're not protecting the back of your neck. You're not protecting your ears. You're not protecting the cheeks as much. And when you start to get a lot of sun exposure to the ears, and you start getting skin cancer on your ears, and then everybody got to whittle away at your ears. You start taking a little piece here, a little piece there. If you wear the broad brim hat, you're going to decrease that risk. We all like our ears. We all want to keep our ears. So try to keep that sun off. Sunglasses, as I was mentioning, are important because you need to protect your eyes. Ultraviolet radiation to the eyes, as I said, increases cataract formation. Melanoma of the eye is actually quite rare, but it can happen. And so anything you can do to keep that risk lower. All right, so do not sunbathe. Anybody in here sunbathe? You probably have. I said, how many of you over throughout your life have had blistering sunburns because you fell asleep in the sun? Or yeah, that's all of us here. Don't do it. Don't do it anymore. Has anybody ever here used a tanning bed? Yeah. Now, sunbathing is bad. Tanning beds are the worst. If you want to talk about something that is completely unhealthy for you, and I got another slide here that shows that it's tanning beds, and I'll explain why in just a second. Protect your lips also, lip balm, sunscreen, making sure you apply it. Now, I will tell you right now, I am not a sunscreen expert. So if you ask me what sunscreen should I use, I will say one that you put on your skin, because that's what you should wear, okay? What kind? I prefer the mineral-based. There's mineral, chemical, but I don't know if it's Sun Bum or Tropical Boat or whatever they are. As long as you find one that you like and use, that's the sunscreen that I like for you to use. So, but what should you look for? There's things you should look for in a sunscreen, okay? You want to make sure you're choosing the right one. We like an SPF of at least 30. Okay, anything less than that, it's all right, but it's not really doing the protection that we want you to get. Using an SPF of at least 30, you're blocking about 95 to 97% of the sun's ultraviolet radiation.
50.
Huh? If you go up from 50 even to 100, that's great. You're now getting from 95, 97 to 98, 99. So you're getting less incremental benefit, but you still are getting a benefit. So if you tell me you want to wear 100, great. Wear 100. I'm not going to tell you not to. I would say just at least use an SPF of 30. You want to make sure it's broad. And what I mean by broad is there's different kinds of radiation. There's ultraviolet A and there's B. So you want to make sure you're protecting from both. A is more for wrinkles, B is more for cancer, but it can be, it's definitely for both. As I said, I prefer the mineral base. The mineral base are those thicker ones, and a lot of people don't like those thick ones. The thick ones coat, they turn you white, and they don't blend into the skin as well for the most part. But that's actually a good thing because it's blocking the rays from getting through. There is the chemical type, which when you put on, actually the skin absorbs it. But either way, if you're gonna use it and you like it, use it. They put SPF in makeup. So if you have makeups that you like to use, you can find different powders that you can put on that actually have SPF within it. Now, here's the key though. You want to apply, how to apply sunscreen. Now, I brought this bottle of sunscreen. We pass this out at all the events that we go to, and this is what we say here, have some sunscreen on us. It's an SPF of 30. This is one application. Okay? This means if you're gonna put sunscreen on, this is how much you should be putting on each time. Okay? It's not just putting a dab and rubbing in here and say, oh great, I'm protected. You gotta get enough on you where it can get onto the skin, protect your skin. You wanna put it on at least 30 minutes before you go out, because that does allow the skin to absorb it, make that layer. Instead of just going out, you're not quite there yet. And you do wanna cover all the areas that are gonna be exposed to the sun. It's not meant for babies. Babies shouldn't be in the sun anyway. They should be protected. And then you want to be able to apply it multiple times. This does not last you the whole day. This will last you about 2 hours. Okay? So if you're going to be outside a lot, you sweat, you You wipe it off. If you're swimming, you see these sunscreens that say, oh, it's waterproof. I can just go in the water and not worry about it. It's not waterproof, it's water resistant. And these last for about 80 to 90 minutes in the water, so they do get rinsed off. So if you are gonna put it on and go out in the water, then you're gonna wanna put it on again. What I tell people who play golf, I say put one of these on when you start and put one of these on after 9 holes at the turn, just because it gets you covered up again and it makes sure that you are protecting your skin throughout. And as we said before, even on cloudy days, you still wanna put your sunscreen on. So this is kind of going over the 2 different types that I talked about, the physical or the mineral-based versus the chemical sunscreen. And there's been a lot of issues in the past with the chemical sunscreens because some of the chemicals they use actually could be carcinogenic, meaning could make cancer, but you needed a lot of exposure and a lot over time. I think that got a little overblown in terms of, oh, well, sunscreen's not healthy because it's gonna cause cancer and I don't want cancer. Ultraviolet radiation is much more likely to cause cancer than any sunscreen is going to cause you. So whether your bias is that you don't want to use it because you think it's going to cause you cancer, get that out of your head, because the ultraviolet radiations you're getting is going to be a whole lot worse. And you can see here why I like the mineral sunscreen, because it reflects. It doesn't allow that ultraviolet radiation to penetrate. The one that's on the skin, the chemical ones, will allow that ultraviolet radiation to hit the skin, but it gets absorbed once it hits the skin. It's more of just, don't really care which one you want to use, just use one, okay? All right, now back to tanning beds. Why are tanning beds so bad? Everybody goes to a tanning bed, and even the tanning bed places say, oh, you need ultraviolet radiation, it's healthy for you, it's good for your skin. And that's actually not a lie, but you need about 10 minutes of sun a day to really get that amount that you need to help convert vitamin D in your skin to just get that good overall health. But the amount of ultraviolet radiation people receive from tanning beds is so abnormally high that this accelerates skin cancer progression so quickly. A tanning bed is actually considered a class 1 carcinogen. What else is a class 1 carcinogen? Cigarettes. So you're not going to go out and tell your teenager, oh, go smoke some cigarettes, it's healthy for you. Just like you shouldn't tell your grandkids or your kids, oh, go out and use a tanning bed, it's good for you. And what I think is even more important is that I'm seeing teenagers, 20-year-olds, 30-year-olds, with really bad skin cancers, with melanomas, with Merkel cells, all these things that are caused by ultraviolet radiation. If you're smoking, you don't see those cancers until you're 60, 70, 80, right? They don't show up till so much later in life. But because the tanning beds offer so much radiation so quickly, and to people whose skins aren't ready to take that, we're seeing these cancers show up in years, not decades. So if you take, well, you should be taking a lot away from this, but one of the key things you should take away from this, if you know of anybody using a tanning bed, whack them over the head, tell them to stop, please. Okay? And if you know of any of your kids in here, any of your grandkids are here saying, oh, I just need that tan for prom just to look good, kick them in the butt, okay? Because a tan for prom, what we have to really get people to understand is tanning isn't beautiful. You know, the whole Band of Soleil thing that came out in the 70s that said, oh, you gotta look beautiful. Porcelain is beautiful. That's my motto, be porcelain. It's like those beautiful dolls. That's what you want to be, because it's gonna ultimately save your life and save somebody's life. But if you do get a skin cancer, if you're at risk of getting skin cancer, what should you do? Early detection is key. So hopefully when you all see your doctors, you're saying, hey, can you look at my skin? And a lot of primary care physicians aren't really comfortable looking at the skin, all right? And they'll say, well, let me get you to a dermatologist. Perfect. You want to make sure you have someone who's comfortable doing it. I don't care if it's a nurse practitioner, a PA, a physician. If someone who's competent is looking at your skin, that's what matters, because they're going to find things. And you're going to say, oh, they missed it 3 times and then it turned into cancer later. Yes, that happens. But the more somebody is looking at something, the more likely they're going to find out that something is wrong, okay? There are precancerous lesions on the skin that someone can look at and say we don't have to touch, and these are things such as actinic keratoses or atypical moles on the top, but you follow things over time, or if you have a relationship with someone, they can follow it over time, and they can start to see that it's changing. Oh, this one's starting to look a little bit more concerning. Let's biopsy it, let's do something, because it could be a basal cell, it could be turning into something more aggressive. If we're going to focus on melanoma a little bit, just because this is such a severe skin cancer, it happens to quite a bit. Did I just do something? Okay, good, thank you. I mean, I probably could do it without, but it's not as fun for these guys here. So there's about 100,000 cases of melanoma a year in the United States. And in Arizona, it estimates about 4,000. I think that's a little bit low. I think there's a lot of things that aren't reported. And I just feel for the number that I see, this number has to be higher. And we do get a lot of people who move in during the winters, a lot of people who move out. So I'm not sure that this true number, but let's just estimate it around 4,000, which is, from a cancer standpoint, that's a pretty hefty number. And as I talked about earlier, we're starting to see it younger and younger. And that's because of going to the beach, blistering sunburns as a kid, tanning bed use. And overall, it's the 5th most common cancer. Now, there's the high ones, prostate, lung, breast, colon, those ones are way up there. But melanoma's right there underneath, and it's not decreasing in prevalence. We're actually seeing more melanoma. Now, with the newer treatments, the risk of dying from melanoma is going down, but we're actually seeing people with more melanoma, so we need to make sure that we're offering talks like this where we can get out and give information and education. So how to spot skin cancer. Everybody's gonna, oh, that one there, that's a skin cancer right there, I'm sure of it. And maybe it is, maybe it isn't. There are things to look for to make sure to see if something looks suspicious or not. For the non-pigmented things, the basal cells and the squamous cells on the top, it's gonna be a waxy lump that's shiny. It sometimes has some raised edges. It gets scaly that just doesn't go away. Now, when I say scaly, that kind of everybody's ears go up because everybody's got scaly stuff on their skin. The majority of them aren't cancer, but if something is scaly that doesn't go away, persists, that's where expert interaction is going to happen, where they can look at it and see it and make sure. And then for the moles we use the ABCDEs, and I use this on every patient I see who shows me a mole, and we look at this mnemonic here. A stands for asymmetry. So a normal mole is going to be nice and round. It's going to be small, and so we can look. But if it starts to get asymmetry where one side is bigger than the other and it's not looking so circumscribed, that could be a concern. That goes with border. The border is crooked or jagged. The body doesn't like to make crooked or jagged things. When the cells grow out of control, that can start to happen. If it's so if it's dark brown, light brown, red, now a lot of moles do have different colors, but if it starts to change into different colors from one that you had, that's going to be important. How big is it? Usually things less than 6 millimeters. We say less than a head of the pencil eraser head. If it's less than that, not as concerning. But as it gets bigger than that, we want to start being a little bit more concerned. And has it changed? Is it evolving? And I think that's the most important thing, is if you've had something on your body that's been there for 20 years, and all of a sudden you look at it and say, I think this one is changing, that's when you should get it looked at. And if you're not sure, what I tell all my patients, if you got one that you're not sure about, we all carry cameras around with us on our phones now. Everybody's got that. Take a picture of it, hang on to it, and then go back to it in a few months and look and say, oh, is it changing? If you're in between doctor visits, you can still look at it yourself and just keep an eye on it. If you think something is changing, make an appointment and get it looked at. So when you have a screen, it's looking at the skin, making sure that everything looks good. The dermatologists have what's called a dermatoscope, and they can actually look at the really significantly magnified image underneath to see what the cells look like or how it presents on the skin, because each of the skin cancers will have certain visualization properties on the skin with that magnification. And they can say, oh, this one needs to be biopsied or this one doesn't. The only way to tell if something is cancer or not is if you get a biopsy. So if it looks suspicious and you say, oh, it's cancer, no one's going to treat you or do anything until they do a biopsy of it. This is one way to do the biopsy. This is called a punch biopsy. Most dermatologists just do a shave. They numb you up and just take a little scoop out of there and send it off for evaluation. So let's say you have a mole, it gets biopsied, and it's melanoma. What do? All right, this is where it becomes a much bigger issue, because with melanoma, as I told you, it has a much higher risk of spread than a lot of the other skin cancers. So the way we treat melanoma really depends on what stage you showed up or how advanced is it. Stage just gives us a way to describe how advanced is your cancer. A stage 1 melanoma is a thin, small lesion on the skin that can usually just be cut off. A stage 2 melanoma means that lesion's bigger, thicker, higher risk of spread. A stage 3 melanoma means it's spread to the lymph nodes. And a stage 4 melanoma means it's spread throughout the body. Now, if any of you have had a melanoma for when you look at your pathology report, there's something that's a little confusing called the Clark's stage. The Clark's stage, this is probably a little bit more detail than you need, but some people come to me and say, oh, I have stage 5 melanoma, and I say there's no such thing. Stage 5 usually means you're kind of underneath that line, not above that line, right? So with a Clark's level, though, it's how deep in the skin does it grow. So Clark level 1 means it's real superficial. Clark's level 5 means it's growing deeper into the deeper tissues. So just kind of be aware if you ever do see that. Clark's level is a little bit different than what we actually mean from stage standpoint. So as I said, the deeper it gets, the different things that we have to do. So if the cancer just grows in the epidermis, when we started off, I told you you have the epidermis and the dermis. If those cancer cells are just in the epidermis, they can grow, but they cannot spread because the blood vessels and the lymphatics aren't in the dermis. So if you have anything that's called a cancer in situ, that means it's just in the epidermis, and by definition, it cannot spread. You want to get it treated before it breaks down or grows deeper. But when someone comes to me and says, oh, I have a melanoma, and it's melanoma in situ, I say, good news. We're going to cut it off, and you're going to be done. The problem becomes is when you start to have this. Let's see here if you can kind of see right there, where it's growing down deep into the skin to where the blood vessels are, right in this area here. That has a much higher risk of spread. So let's talk about stage 1 and stage 2. So stage 0 is melanoma in situ, can't spread. Stage 1, and this you don't need to know all this detail, but just essentially what we're showing here is that as depth increases, and this is how it's broken down to us, the risk of spread increases. If you come to me with a melanoma and I look at how deep in the skin it grows, if it's less than 0.8 millimeters, we're talking really small. If it's less than that, the risk of spread is so low, we're not even going to check for it. But as it gets deeper, that risk increases, and then we're going to start worrying about, all right, has it spread? Let's go ahead and check for it. So how do we check for melanoma once it's spread? Well, when people come to see me, unless they have some obvious sign that it's spread, I don't scan people. Most people will say, oh, I need my scan. Like, no, we're not going to do a scan because melanoma, when it spreads, it's not going to show up on a scan. It spreads microscopically, and you can't pick up microscopic disease on a scan. The only way to see if the cancer has spread is understanding how it spread and then what needs to be done. So when melanoma spreads, it spreads through what are called the skin lymphatics. The lymphatics are fluid channels that are all throughout your skin and drain to lymph nodes. So we worry about lymph node spread when it comes to melanoma, and I perform a process called a sentinel lymph node biopsy, which means I take out that first draining lymph node to see if there's cancer there. That's how we check for spread. If there's no cancer in the lymph node, great, it hasn't spread. If there is cancer in the lymph node, well, that's gonna now allow us to start the ball rolling to do further things. And then we wanna do what's called a wide local excision. Wide local excision just means I'm gonna cut out your tumor, but with a margin of normal tissue. And the deeper that tumor is, the deeper that tumor is, the wider of an excision I'm gonna make. Why is that? Because we know that the deeper the tumor is, not only can it grow deep, but it can spread out laterally. And the studies have shown that you need to do a wider excision for those deeper ones to prevent it from coming back. So if you have a tumor that's less than 2 millimeters in depth, I need to do a 1 centimeter margin around it. That's gonna leave a hole of about a $50 size. People still use coins now. That's a $50. If it's greater than 2 millimeters, I need to do 2 centimeters around, and that's gonna be a full silver dollar size. So that's the kind of hole I need to make. When you make a hole that big in your skin, it's really hard to close that. So the way we close it is we ellipse it down. And people when I'm done with them, if they have a 2 millimeter melanoma, they're gonna walk away with a scar this big. And that's quite impactful. If it's less, for a 1 millimeter, it's about 3 inches. If it's 2 millimeters is about a 5 to 6, and sometimes we need to do skin grafts, sometimes we need flaps, sometimes we just do wound care as well. So this can be really impactful cosmetically, functionally, if it's across a joint, if it's on a toe, sometimes I have to amputate toes or fingers because of this, but we still want to make sure we clear the melanoma so it doesn't come back. Okay. I want to talk about just real quick about that sentinel lymph node biopsy I talked about. So if I have a melanoma on my arm, where are the lymph nodes for the arm? They're going to be in the armpit. So each of the regions of the body has different locations for where they are. So for the head and neck, they're up here, what's called the cervical lymph nodes, along where the jugular vessels are. For the upper torso and the arms, they're in the armpits. And lower torso, they're going to be in your groins right here. So you may walk away with an incision in your groin if you have one on your leg. But we want to know where those lymph nodes are so we can take those lymph nodes out to look to see if there's cancer on it, okay? But each part of the body will drain to a different area. But what if you got a melanoma right here? Well, it could potentially drain to the groins. It could potentially drain to the armpits. If it's right in the middle, the body usually goes side to side, but if you're right in the middle, you could potentially have drainage to both sides, and a melanoma could spread to all of those. I've seen it where I've had people, I've taken out lymph nodes, and they've had lymph nodes in multiple areas. So we know their melanoma has spread to different parts, but how do we figure that out? Just a little detail for you is that we do something called a lymphoscintigraphy. And a lymphoscintigraphy is where somebody comes in and they get their melanoma injected with a little bit of a radioactive tracer. And that's big white spot in the middle. That's the actual melanoma itself. Then that tracer gets taken into those lymphatics and it will go to a lymph node to know where is that draining lymph node. And we can see this patient had, here's the injection right on their mid-upper back. This is one on one side, one on the other side. You can kind of make out the head up here, the arm, the patient's doing this right now. So if we were gonna assess these lymph nodes, I would have to take out a lymph node under each armpit just to see if there's cancer in it. Most of the time there's not, but the only way to know for sure if there's cancer in the lymph node is to take it out and let the pathologist look at it under the microscope. So let's say there is cancer now in the lymph node. If there's no cancer, great, nothing else that we need to do, just go into observation for the most part. But if there is cancer in the lymph node, now we're gonna be talking about different treatments for melanoma, either if it's in the lymph node or if it's gone beyond, as I told you, for either stage 3 or stage 4. One of the ways we treat melanoma when it's advanced and it's spread is something called immunotherapy. A lot of you may have seen these commercials now for immunotherapy, Keytruda, Opdivo, they're getting on TV a lot. But what the immunotherapy does, it actually takes your body's own immune system, ramps it up to go after cancer cells. Before we had immunotherapy, melanoma, I would tell you, was pretty much untreatable. People died from melanoma all the time. With immunotherapy, it's been a game changer. I've seen people with widespread disease who we've given this drug to, and their tumors have melted away. It's been amazing to be part of this process over the past 5+ years as immunotherapy has come to market to see how well people are doing. Now, it's not gonna be everybody. Some people are gonna be resistant, but before when we had only about a 10% response rate for melanoma, now we're seeing 50, 60, 70% response rates. It's been wonderful, to be honest with you. One of the other ways to attack cancer, melanoma, when it spreads, is there are certain mutations that can happen in the genes that cause that cancer to grow, and you can target those mutations, and that's called targeted therapy. So if you have a mutation that will make an abnormal protein, you can make a drug that will go after that abnormal protein, so it'll theoretically only impact the cancer cells and not impact the normal cells. And people can do quite well with that. And for these immunotherapies and targeted therapies, we've treated 90-year-olds with this, and they've done well, they've tolerated treatment. It's not chemotherapy, which to give a 90-year-old chemotherapy, you're probably not gonna do because that's a poison that goes throughout the entire body. But for my older patients and my younger patients, we have options to treat. People ask about radiation. What about radiation? Radiation definitely has its part for skin cancer. For melanoma, a little bit less, but someone earlier told me they had a desmoplastic melanoma. There are types of melanomas where you can consider using radiation to prevent the risk of it coming back, and even if it has spread, to treat the spread. We have clinical trials at our institution. We're looking at trials that are looking at things where you could inject into the tumor. Maybe we can cause some problems if you inject something into the tumor to get this really a robust immune response, and now we can use immunotherapy afterwards. That seems to be a great way to do it. Vaccines. People are asking about vaccine trials. If you can give somebody a vaccine with a certain, if a cancer cell has a certain protein, and you can make a vaccine to that protein, well, maybe you can cure somebody or prevent them from getting cancer in the future. And that's a promising line of clinical trials right now. And we're doing a lot of them at our facility. Then let's just touch about the non-melanoma stuff. While I harp on the melanoma just because it is so much more aggressive, the non-melanomas, basal cells, squamous cells, and others can still spread. Typically, surgery is going to be the most important treatment for that. But if it has spread, then we can consider even immunotherapy for those. We can also do radiation for a lot of squamous cells and basal cells. Cryosurgery is a reasonable option. Topical chemotherapy, Fudex, some of you may have been ordered that before. And then even the systemic going through the IV for the immunotherapy or the targeted therapy. All right, so what I want you to take home from this talk today, protect your skin. Okay? Even now, if you continue to if you continue to get that radiation, continue to beat up your skin, you're gonna make it worse for you. Get your skin checked. If you have something that's concerning, get someone to look at it. Even if you don't, you might not see something. Go to an expert, make sure somebody else is looking at your skin so they can look at it and either say, no problem, we'll see you next year, or say, oh, we need to biopsy this, or not sure, why don't you come back to me in 3-4 months. And finally, if you know somebody, if you're using tanning beds, if you are sunbathing, cut it out. Stop it. All right, thank you for your time. I hope this was educational for you. I ran through a lot of stuff, I know. Hopefully, if you had any questions, you wrote them down. Claudia, should we just jump into? All right, so there is a microphone going around, so if you do have a question, just raise your hand, and we'll have that come around, and feel free to ask your questions.
I think one of the questions that women always wonder about is, should we put in the, we have to put moisturizer on our face, got that, right? And our serums. So are we supposed to not do that in the morning? Because, we're not going to want to do that. And if we put I've heard we should put the sunscreen on first, save the serums and the moisturizers for the night. Or can we put some moisturizer on and then use, like, one of the things I use is Elta MD, which is the tinted sunscreen. So this is a real problem, and I'm sure I'm not the only one with this question. If you could address that a little bit.
I'm not the sunscreen expert, as I said before. I am a surgeon, so if I can't cut it out, not as good at it. But what we do know, and I will just reiterate, protect it. How to protect it? Usually you want it on first because that's how it's going to get absorbed. Now, there are a lot of makeups now that have the sunscreen built into them. Maybe it means changing what you're doing or how you're doing it. If you are putting your makeup on in the morning, it means you're probably not going out in the sun anyway too much. Just be smart about it. I'm sorry, I don't have that answer for you. Some of my colleagues here actually who utilize that and purport it, I don't know if either of you, Sandra or Marisa, have thoughts on the makeup portion of it.
Okay, so normally when you're gonna do it, you're gonna wash your face, do your serums, do your moisturizer, then your sunscreen, then your makeup. If you wanna have a moisturizer that has sunscreen in it, that's okay too, but we typically only put those moisturizers and makeups on our face, and we wanna make sure you get your neck and your chest as well.
Thank you. Please, we have a question up front. Don't be shy, you all have questions. I'll answer them for you. We're gonna come up front here first, I think, and we'll just get a couple microphones going around it.
The question I had was a couple of screens back, you had how the body can fight cancer. Those sound too good to be true. Are they in effect now, and do they work?
You mean the treatments that we have? The immunotherapy? How you can ramp? So yes. So we know that, say you have an infection, okay? Why does our body fight infection? It fights infection because these bacteria or virus present proteins that are in your bloodstream, that the white blood cells that are circulating around can identify that as foreign, okay? If you think about cancer is your own body growing out of control, and it doesn't look at it as foreign, right? It can just keep growing because the body says, oh, that's me, I don't need to attack that. But now what these class of medications do is they take those brakes off the immune cells, and those immune cells can now recognize cancer as foreign. Does it seem too good to be true? Yeah, it does. But as I've said, I'm seeing people who have disease. You should see some of these scans where people, it looks like they've got a constellation, stars all through their lungs and their body. We put them on immunotherapy, and after a couple cycles, their scans are clean. It's fantastic, and it's so exciting to see. So we do have options now. Before, when we didn't. And targeted therapy as well. We're seeing this, some people can't get immunotherapy. If you have autoimmune issues, Crohn's, ulcerative colitis, bad rheumatoid arthritis, because we're ramping the immune system up with these drugs, it's hard to give somebody whose immune system's already overactive a drug that's going to make the immune system even worse. So there are people who we can't use immunotherapy in, but maybe we can target their lesion, or maybe there's other ways to go about it. But does it seem too good to be true? Yes, and that's what's so great about it. Yes, please.
Almost every time I go to the dermatologist, she freezes various things. But what does that do, and how effective is it?
It helps pay for her car. No, I'm just kidding. So, as I've told you, a lot of the non-melanoma skin cancers can start off scaly or be small. And freezing it's a good way to take care of that, where you don't have to do a biopsy. Now, if you have to freeze something multiple times and it keeps coming back, then it should be biopsy. But sometimes it's hard to tell if something's precancerous, something's cancerous. Do we need to cut it off? Well, let's freeze it, see if that'll kill just the because that's just epidermis. And if it's not deeper, maybe that'll take care of it. So freezing it is a local treatment. It's almost like just doing a tiny little cut just to take it off. And if it goes away and it doesn't come back, then that's been the right answer. Now, if you're getting something frozen 2, 3, 4 times, maybe we aren't freezing it anymore. Yes, in the front we have a question. They'll bring you a microphone so everybody can hear it. It's coming.
I got it. Okay. Hi. My daughter-in-law had melanoma right after she had her first or second baby. And that was like 26 years ago, okay. And now it's come back in a different area. Now, is that the same melanoma, or is that hard to say?
Well, good question. So melanoma can always come back. The most highest risk of a melanoma coming back is going to be within the first 2 years or so, and I follow people pretty closely in the first 2 years, but that risk of coming back does decrease over time. We've seen people come back with melanoma 10 years, 15 years later. Now, if she had a melanoma that was removed and she gets another spot on her skin, and that skin gets biopsied and it says this is a melanoma of a certain depth, that's a new melanoma. Okay? We know that once you get one melanoma, you can get more melanoma because the skin you've hit that impact level. So it doesn't mean that her melanoma is spreading. Now, there are certain features, if they biopsy it or see it, if it's under the skin, it'll look different than if it's on the skin. And if you get stuff that's under the skin, that usually means it's traveled through the lymphatics or through the blood and dropped off there, and that could mean that it is spread. But most of the time when someone gets a melanoma and then they get another one a few years later, it's a brand new melanoma, unrelated. It just means we know your body can make melanoma. You're going to be at risk of making more melanoma. Once you get one, you're more likely to get 2 and 3. So probably a new melanoma for her. But it's an interesting question because I do see a lot of pregnant patients, not a lot, a good number of pregnant patients though, who get melanoma. And their melanomas can grow like crazy. And why is that? Well, when you're pregnant, you have all these growth hormones circulating through your body. And I've seen some really bad melanomas in pregnant women, and it's devastating in terms of how to manage these patients, because do we wait for the child to be born? Do we talk about aborting the child if it's early on for the health of the mother? A lot of difficult questions that we have to answer at that point, but we do see that. Question here in the middle? Hang on, I can't hear. They're going to bring you a microphone, okay?
Is there any way to grade a melanoma of the eye? Because, personal experience.
To grade.
Everybody.
So there's I would say there's 2 types of eye melanomas. There's some that actually can happen that they grow locally and they don't do anything. There's some that show up and spread throughout the body like wildfire. So there's actually 2 different types. There is a test out there that can actually pick up what that risk is or what the type that is, and that's within standard staging criteria. So it can help you do that. Problem with melanoma of the eye, sometimes it's radiation, a lot of times it's removing the eye as well. But if it's just a local phenomenon and you can remove the eye, that could be curative as well. Problem with the ocular melanomas, they have a high risk of spread if you're in that other type, and it's usually a lot of times we'll see it in the liver, and then we'll see it beyond. But yeah, there are definitely 2 types within that, but a much more rare It can, yeah, all melanoma can go to the brain once it's spread. Ocular melanoma has a higher risk just because you're already at the ocular nerves. It can go back and go right into the brain. Yeah. All right, anybody still perusing, thinking, this is your one chance. I'm gonna be off the stage soon, come on. All right, so when I do this and I have to cut on you, cutting isn't a bad thing because we always, as a surgeon, we say a chance to cut is a chance to cure, right? Cold steel is the real deal, right? So we actually want to be able to cut these things off because if we can cut them off, it's early and they don't come back. That's the goal. If they've spread, we have good treatments to take care of you with. But before you get to that point, try not to get to that point, all right? Protect your skin, get it looked at. I thank you all for allowing me to be here today. It's been fun for me to talk to you.
Thank you, Dr. Gimbel. That was an amazing presentation. We have a small token of our appreciation. Thank you for coming out here. Let us know if it doesn't fit. Thank you. Just so you all know, this presentation has been recorded and it will be posted on our website. So just give us a few days. And also, oh, thank you. Sorry about that. This presentation is being recorded and it will be posted on our website. So we will be sending you that link and please let us know if you don't receive it. Also, we always welcome your feedback. It helps us make sure that we're bringing presentations and physicians that have topics that you want to hear about. So there's a survey at your table. So if you could please fill that out. And then also I should let you know that our Coffee Connections will resume in September. So we're going to take July and August off. But learned a lot today, of course. So let's make sure to take that annual checkup, you know, for our sunscreen and don't do tanning beds. Right? So just what's upcoming. Put this on your calendar. We're very excited. This is our inaugural Live Well conference. It's going to be a 2-day event. And as a matter of fact, the team of MD Anderson was telling us that they're going to be participating, and we're excited about that. There's going to be panels. Our keynote speaker is going to be Dr. Arthur C. Brooks. If you want to look him up, he's quite the extraordinary author and talks a lot about healthy aging and the things we can do to get ahead of much as we can, and really has to do a lot with prevention. And then also, if there's anything the foundation can support you with, here is our leadership, Nora Hanna and Brian Dowdle. As I said, my name is Claudia, but we do have a lot of our team members here today that you can connect. There's Pamela back there, we have Jazz, we have Stephanie, and then the rest of the team, of course, that is from the foundation that can answer any questions you might have. Thank you for joining us, and we look forward to seeing you next time.
To learn more about Sun Health Foundation initiatives, become a donor, or attend a future Coffee Connections event live, please visit us online at sunhealthfoundation.org or call 623-471-8500. Sun Health, empowering people to live longer, healthier, and more purposeful lives.